one more quick poll that is going to help you, let's see, tell Jody what you are most interested in as far as which psychotropic medications you would like the most information about. So I'm going to go ahead and launch that poll and give you a moment to answer that. And then I will give those results to Jody, and then we will turn it over to Jody. Looks like about half of you have had a chance to vote. Okay, just a couple more seconds and I will close the poll. Okay, and I will go ahead and share those results. You should be able to see those on your screen, and it looks really spread across the board. So 49% of you would like more information about stimulants, 46% antidepressants, 43% mood stabilizers, and 37% antipsychotics. So definitely it looks like you really would like information on all of those, and so I think you will be pleased with Jody's presentation because she will do a great job of covering all those. So at this point, I am going to turn the presentation over to Jody, so just bear with us for a moment as we switch screens.
All right, everyone should be able to see my screen at this time. And I will give you just a little more information about myself. I started in community mental health in 1992, working with adults experiencing severe and persistent mental illness who were being deinstitutionalized and brought back to their communities. And it was at that time I became very interested in the issue of medication because I saw what a difference it made in people's lives. Since that time, my focus has really shifted more to children and developing some early childhood programs here in Sedgwick County. So my interest in medication has continued, and we're going to spend a little bit of time talking about that today. First of all, I want to start off with talking a little bit about medication and boundaries and roles in discussing medication. Often I find people are hesitant, professionals are hesitant to talk about medications for fear that somehow they're practicing outside their scope. When in reality, I think it's very helpful for us to have information about medications so that we can help children and families along with the med providers. So we're going to talk a little bit about some rules to follow, and I kind of call these my golden rules. Knowledge is a good thing. Being able to have enough knowledge about the medications, the potential side effects, their benefits, can help us in working with prescribers to benefit children. There are also risks with all of the medications we're going to talk about today, and it's critical that we have enough information to know when there might be a problem with a given medication so we can alert a medication provider or help in that way. So knowledge can be very helpful. We just need to know our limits. One of the things that sometimes happens is when we get this knowledge, sometimes we unintentionally irritate the prescribers, is the best way I know how to put it. Medication providers, doctors, ARMPs, physician's assistants, they really are the experts. And so it's quite appropriate for us to give them feedback about side effects or a concern we might have or how a medication is being helpful to have that information. But we definitely don't want to appear to be giving them direction about their practice, such as saying you don't think the medication dosage is correct, or saying that the medication isn't the appropriate medication for that child. Rather, it's more helpful for us to talk about symptoms, side effects, concerns we might have, or benefits we're seeing to give them that feedback. But ultimately, they're the prescribers. And most importantly, it's important that we don't appear to be practicing medicine without the proper license. And by that I mean we shouldn't ever tell a family, you need to get your child on this specific medication. That's really getting into prescribing, which needs to be left for the professionals who have the proper license. We're going to start off today talking about stimulants. This is something we see quite a bit in young children who have behavioral problems. Someone may be prescribing a stimulant. These are used almost exclusively to treat attention deficit disorder and attention deficit hyperactivity disorder. And ADHD can include the inattentive components as well. These medications are really thought to, the stimulants, thought to address issues with the frontal lobe and the prefrontal lobe for persons who have ADHD or ADD. The general belief is that that part of the brain is not functioning as quickly as the rest of the brain, and things are sort of out of sync, if you will. If you understand the purpose of the frontal lobe and the prefrontal lobe, that's really kind of the executive functioning part of the brain. It helps you control your impulses, plan ahead, anticipate consequences, regulate your emotions, and if that's not functioning quite right, you can see the symptoms of ADD and ADHD. So these medications are thought to address that deficit. They're all stimulants. Typically, they're going to be an amphetamine derivative or a cousin to that type of medication. Ritalin has been around for decades now and has been prescribed to millions of children at this point. Some of the pros and cons of Ritalin are that the pros are it's very inexpensive. So if a person is uninsured or can't really afford their medications, it is available in a generic form and it is very inexpensive. Some of the cons are that it doesn't last that long in the system, typically about 4 hours, and then you need to redose. So for many children, that would mean a morning dose, a noon dose, and then even possibly an afternoon dose. When you have multiple dosing in the day, then sometimes there are going to be issues around medication compliance. Do they get every dose? The other thing we saw with Ritalin when it was used much more frequently was for some children, as it was coming out of their system, they would have what we called rebound effects, where they might be more emotional, crying, kind of distraught, upset, until they got the next dose. With the newer medications I'm going to talk about, we don't really see that as much, but Ritalin is still used. And it is very inexpensive for families that can't afford the other medications and don't have access to insurance. Adderall was probably the next medication I saw being used fairly extensively for the treatment of ADD and ADHD. It is available in an extended release form. And I do want to talk a bit about extended release medications. Any medication, stimulant, mood stabilizer, any of those that are extended release, it is really important that those pills are not crushed, broken, split, because it is the coating on those pills that allowed them to be extended release. So if they're chewed or broke, split for dosing reasons, it really destroys the extended release factor for that medication. So I would never do that on an extended release medication without a doctor telling you to do so. And often you'll know they're extended release because the name of the medication might be followed by the letters XR or ER, or in the case of Metadate, CD comes after that. So there is Adderall. It is available in extended release, which would mean it typically lasts 6 hours, maybe 8 hours for the child to get them through the school day, morning dose. Concerta was the next medication that came along that we saw, and there's a component to Concerta that's really helpful if there are concerns of abuse of the medication. In all of the stimulants, we have to be very concerned about abuse of the medication being maybe diverted from the child and sold, because many of these meds have street value. Concerta is in a capsule that is extended release, but the way the capsule works is if you try to open up the capsule to, say, misuse it in another way, it turns to a sticky gel, and you can't snort it or use it in an inappropriate way, which is a good thing about Concerta. So lower risk of abuse than we saw in some of the earlier stimulants like, say, Ritalin, which can be diverted away from the child for street value or misused by crushing and snorting the tablet by maybe other persons in the child's life. Concerta also has a longer acting characteristic to it because of the way the capsule's developed. It's basically a little pump in the capsule. Typically, we're seeing children benefit from this medication for about 10 hours in a day, some less. Some kids metabolize quicker, maybe some a little longer, but it has a little longer acting value. Focalin is another medication available in an extended release. However, it is a medication that the capsule can be opened and sprinkled on food for very young children who maybe can't swallow a pill or have an aversion to a pill. I would work with a medication prescriber before doing that, but that is one of the advertised components of this medication, that you can sprinkle it on food and it will still be extended release. I believe the pellets inside the capsule, the coating on the pellets themselves, act as an extended release mechanism. Metadate is also available in extended release, so once a day dosing to get you through the day, and the CD formula can also be sprinkled on food. More recently, we have our first medication for ADHD that's available in a patch, and that's Daytrona. Daytrona is a patch much like the nicotine patch for adults, where you would put the patch on the child in the morning, and they will get benefit from that patch throughout the day. The patch is recommended to be removed at least 2 hours before bedtime so that the stimulant has a chance to come out of the child's system so that it doesn't disrupt sleep. But some children wear it, even closer to bed than that. But you really probably get the longest action out of the Daytrona patch. It has low risk for abuse, or lower risk for abuse, because once the patch is removed, it cannot be reused. So there's really no street value. A child could not take their patch off and give it to a friend to wear because once it's removed, it's no good. It can't be reused. We have had a couple of cases early on when the medication first came out where the sticky component of the patch caused a bit of a rash for some children. That seems to have been resolved, but within any medication, there may be somebody who has a reaction to it. They often recommend kind of moving where you use the patch around so that it doesn't cause skin irritation, but I haven't heard of any concerns with the skin irritation in quite a while. Then we also have Vyvanse. Vyvanse is a stimulant, but it also has a mechanism by which it has a lower risk of abuse in that this medication only works once it hits the gastrointestinal tract. There's an enzyme that needs to react with it in order for the medication to work. So again, not much street value. It can't be crushed and abused that way, and it is long-acting. It will also typically get a child through the day and help them be successful. For those families who have concerns about stimulants, there are some non-stimulant options. And these would be Strattera, Clonidine, Tenex, and Intuniv. Intuniv being the most recent one, and folks may have seen some commercials in the last few months for it. Strattera is a non-stimulant that needs to be taken for really a couple of weeks before you're going to know if it's helpful, which is very different than the stimulants. The stimulants, you're going to know that day whether or not the child's getting some benefit from the medication because it comes on board quickly and then it leaves the system quickly. Strattera is more similar to the action of an antidepressant where you really have to take it daily and it's going to take several weeks before you know if it's helpful. We see kids who have maybe some ADHD symptoms and co-occurring anxiety who may benefit from Strattera. The stimulants might make anxious symptoms worse, and Strattera would not. And it seems to help with those children. And then also, again, with some families who are reluctant to do a stimulant. Stimulants are the gold standard. That is the preferred treatment for ADHD, but these other options are also effective. There's also Clonidine, which Clonidine really is probably much more effective in the hyperactivity type symptoms than any inattentive symptoms. But if you have a child, especially young children who might be quite hyperactive, you may see a physician try Clonidine to help calm them down so that they can function at school or in a daycare setting or preschool. Tenex and Intuniv are really sister medications. We've had Tenex for quite a while, and then most recently they launched Intuniv, which is just a slightly different chemical compound. But these two medications are more similar to Clonidine in that they help with a lot of the hyperactivity and maybe calming the child down so they're much more able to participate in activities. With the stimulants, the most common side effects are going to be poor appetite because they are stimulants, insomnia, and in some kids they may cause increased restlessness. The insomnia issue is often managed by making sure that they're given the medication at the proper time each day so that it has left their bloodstream in time to be able to go to bed at night. So, for example, if a child's supposed to be taking Concerta, they really need that dosing first thing in the morning. If they miss the dose for whatever reason and say it's not discovered till 1 o'clock in the afternoon, typically they're going to recommend against giving the dose at that point because the child probably will have trouble going to sleep that night. And as we all know, children who don't get adequate sleep are also much more irritable and have much more difficulty the next day. So the stimulants need to be given at the proper time to make sure that they're out of their bloodstream in time for bed. Less of an issue with Strattera, Clonidine, Tenex, and Intuniv. With the stimulants, we also need to watch for any adverse side effects with regard to heart rhythm or blood pressure because of their stimulant component. It's fairly rare. You don't see it often, but the providers, the med providers, will typically be monitoring blood pressure and heart rhythm to make sure there's no adverse side effect there. At this time, I do want to stop and take any questions people might have for stimulants before we move on to the next section.
Okay, Jody, we have had a couple of questions come in. One is finding an effective ADHD medication somewhat trial and error?
A good trained psychiatrist or ARNP with psychiatric training is often able to assess the symptoms and narrow it down to maybe a type of ADHD medicines that are more likely to be successful. There is going to be an element of trial and error. For example, if a child tries Adderall and it's not really working well for them, you'll typically see the med provider switch to a different type of stimulant, such as Concerta or Metadate, that are in a different class of stimulants to see if they get a better response. But they can usually narrow it to a type of medication, but then there may be trial and error to either find the right one or get the right dose. Often we see people abandon a medication too soon when maybe the dose wasn't quite right yet.
Okay, great. Thank you. We have had some more questions come in. One is, are you familiar with the medication Capvay, K-A-P-V-A-Y?
I am not familiar with that medication, and I don't believe the medication prescribers I work with that's one of the medications they are currently using, but I definitely could check into that.
Okay, great. Thanks. And another question is, we've had quite a few come in, so is it common to combine Focalin and Clonidine? We have a child on these, Focalin in the morning and Clonidine at night.
Yes, you very well may see that combination. Sometimes what they're doing is using the Clonidine to help the child calm then in the evening to be able to go to bed.
Okay, and the next question is, where can a parent in Topeka get their child tested for Adderall abuse, taking it when they are not supposed to be?
You would want to work with your medication prescriber. The stimulants would show up on either a drug screen or possibly on a urinalysis that could be done at a lab, and they could check for the levels to see if the levels were beyond what the dosing would suggest would be in their system. But I would work with the med prescriber because you would probably need an order from a physician or a ARNP or PA to get that lab work done to check that.
Okay, great, thanks. I think we had someone raise their hand, and so I have unmuted her. So, Christina, would you like to go ahead and ask your question?
I don't know how it got unmuted. It must have been a glitch.
Okay, so you don't have a question?
No, I don't.
Okay, all right. We did have one more question, Jody. Are you familiar with ADHD medications causing extreme irritability or even anger or rage reactions?
Yes, that can happen. It's not a typical side effect, but it can happen. I have seen it happen in my own experience with Adderall. But I have been told other medications can cause that as well. And in the case I'm familiar with the individual with the Adderall extended release and the irritability it was causing, that was resolved immediately when the individual switched to Concerta. And that was the thing I was talking about earlier, that sometimes if there's a reaction with one class, they may try a different class with a slightly different mechanism, and that may resolve the issue. But yes, I have seen that happen.
Okay, thanks, Jody. We might have one more question. We have a hand raised, and so I'm going to unmute and see. Katrina, do you have a question you'd like to ask over the phone?
If that's me, no, and I don't
Okay.
have my hand down on my screen.
Okay. For some reason, we're having some mysterious hand raising. Aren't really raising their hands, so I'm not sure what's going on. But I will go ahead and turn it back over to you, Jody. That answers all of the questions on that section. Thank you.
Thank you. So now we're going to talk a bit about antidepressants. The antidepressants are typically used for the treatment of both depression and anxiety disorders. The way to kind of conceptualize this is anxiety and depression are really closely related. And for people who have problems with anxiety, it's not uncommon for them to also experience depression from time to time. And anxiety can be a symptom of depression for some people. So they're really closely related, and the medications are used for both. The medications you're going to most commonly see used are TCAs, which is tricyclic antidepressants. These are a class of old antidepressants that were really the first ones out, but periodically you'll still see them used. Most of those medications end in kind of amine at the end of it, A-M-I-N-E, like dazipramine, those type medications. Don't see them used a ton in very young children, other than you may see trazodone used in young children. It's an antidepressant. It's an old one. It also helps with sleep. So for kids who may be anxious, depressed, can't go to sleep at night, you may see trazodone used as kind of this dual benefit. Helps with sleep, but may also help with mood. The more common class of antidepressants you're going to see in children, especially younger children, is going to be the SSRIs, which stands for selective serotonin reuptake inhibitors. These medications all work by helping increase the amount of serotonin available in the brain to be used, which is thought to be a contributing factor to depression, that you don't have enough serotonin available in your brain, and so it's not quite functioning correctly. Prozac has been out now really probably for about 30 years or close to it. It is available in generic, and it's also available in a once-a-week dose, which initially I think we were all excited about because you'd only take a pill once a week, but there are challenges in remembering to even take a pill once a week. All of the SSRIs are going to be typically dosed once a day. Could be dosed in the morning, could be dosed at night. Some people find these medications activating where they may not be able to go to sleep right after they take it. For other people, they have a paradoxical effect where it's more sedating and they need to take it before bed. We also have Paxil. I believe it's out in generic now. Zoloft. Zoloft is one that I see used more often when there is depression and anxiety or even obsessive-compulsive disorder. I see folks using Zoloft, and I believe it is approved for that use, though it may not be approved for that use in children. Very few of these medications have been approved for use in children because there just aren't enough studies with children yet at this time to get that approval. More recently, there was Celexa and Lexapro in the SSRIs, and they're very similar chemically, but just enough different that they are separate medications. Of the kind of atypical antidepressants, if there's such a word, there's Wellbutrin and there's Effexor. Wellbutrin may be dosed twice a day. Effexor is almost always dosed at least 2, maybe 3 times a day. But if the SSRIs did not work for the individual, you may see a prescriber try one of those 2 medications to treat depression and anxiety. Some of the common side effects that I see with antidepressants are the sedation or the activation. And then you just need to administer the medication at a time of day where this is not going to cause problems for the person. For others, it's GI upset, stomach upset. What I tell folks is, especially when you're starting one of these medications, it's really important to take it with some food. Taking it on an empty stomach seems to cause more problems. Even if it's a piece of toast, it just seems to help. Dizziness may be another side effect. Early in the course of treatment, I've had folks tell me that if they stand up too quick, they kind of feel a little dizzy. That typically passes. And not so much that this is a concern in preschool age children or very young children, but in adolescents, the issue about sexual dysfunction can be problematic for that individual and cause them to resist wanting to take the medication. Adults, for sure, that is sometimes a reason they don't want to take the medication. One of the things we need to talk about is the black box warning that is on all of the antidepressants for children and young adults. There is some research that says starting an antidepressant is associated with a slight increase in suicidal ideation or suicide attempts after starting the medication. But I want to give you some information about what that risk really is. With a placebo, a fake sugar pill, after starting it in studies, there was a 2% increase in suicidal ideation or gestures. With an antidepressant, that increase was 4%. So it is only 2% greater than a sugar pill. The risk is still very, very low, but it is something we need to watch for. What psychiatrists have kind of explained to me they think the issue is that when you're really profoundly depressed, you may not have the energy to act on your thoughts. When you start these medications, you may start feeling a little better before all of the negative thoughts are resolved, and so you may actually have the energy to act on some of the thoughts you were having all along, which may be what the risk is really about. So typically a medication provider is going to want to see the child very frequently, at least every 2 weeks, when they first start an antidepressant, to make sure that the child's doing okay, there's not a problem with suicidal thoughts or actions. And it's important for caregivers, those of us working with children and families of children taking these medications, are aware of this risk and that we are watching for that as well, because that could be you know, very problematic for the child if not attended to. So that's really antidepressants in a nutshell. Mostly I see the SSRIs being used in younger children where there's a concern about depression or anxiety. But occasionally, like I said earlier, you may see trazodone being used in addition, or you may see Wellbutrin or Effexor, but not as common in the young children. At this time, I want to take questions about antidepressants, if there are any.
Okay, right now it does not look like we have any questions. We can wait just a moment and give people a chance to type one in if they have one, if you would like.
Sure. And if they think of one, they can always ask, and we'll look at that at the wrap-up.
Okay, that sounds good. Yeah, it doesn't look like there are any right now.
Okay,
So
all right.
Wrap up.
All right, now we're going to talk about mood stabilizers, of which really all of these medications that we're going to talk about today are also used for the treatment of seizures. We don't really understand the science that well at this time, but there seems to be some sort of overlap for these medications to have dual use. So these medications are used, the way we're going to talk about them today, used for the treatment of bipolar disorder, and they are sometimes used for treatment-resistant depression when an antidepressant alone has not been enough to assist in alleviating the depressive symptoms. They may also add a mood stabilizer. Occasionally, I've seen these used in some children who have very significant anger problems, difficulty regulating their mood, and they may try one of these to help better stabilize that mood. The most common you'll see in children, young children, if it's being used, would probably be Depakote, sometimes Lamictal or Trileptal. You rarely see lithium being used in very young children because some of the potential risks with it. But I'll talk mostly about Depakote since that's the one I've seen most frequently used in young children. Depakote is dosed typically twice a day, morning and evening, and it will take a couple of weeks probably before it is on board to whether we know whether or not it's going to be helpful. You do need to get labs done with Depakote to make sure the dose is in the therapeutic range in the bloodstream. If it's too low, it's not going to be helpful, and if it gets too high, it can also be dangerous. So for an individual on Depakote, it's critical that they get their labs like they're supposed to so they can be monitored to make sure that the medication is both going to be effective, but it's also not going to be toxic and potentially harm them. One of the things about Depakote that I have personally seen after really at this point in my career, probably close to 100 children on Depakote, I would have to say, is the issue of weight gain. What I have learned in talking with children and adolescents on Depakote is that on the medication they are seriously more hungry than normal for that child. That it's almost as if the part of the brain that tells you when you're full doesn't function so well when they're taking this medication. So they really are experiencing hunger, and they tend to overeat, and then there's weight gain. For adolescents that I've seen on Depakote, it is not uncommon that they gain 20 pounds, maybe 30 pounds, if we're not really careful in working with them. So one of the things I work with families about when a child's on Depakote is making sure there are healthy snacks available, because a child is hungry. If you just try to tell them not to eat, you may have more problems with irritability and temper tantrums because the child is experiencing hunger, but it's going to be problematic if they're snacking on high-calorie, low-nutrition value type foods like potato chips, Little Debbie's, things that may taste really good but not have much nutritional value and high calories. So things like baby carrots that they can crunch on, other fruits and vegetables can be much more healthy and still allow them to have snacks when they're feeling hungry. Lithium, as I said, you don't see used a lot because it is a salt. Lithium is a form of a salt, and there is risk of damage to the kidneys. If the level gets too high, the individual gets dehydrated and their levels get too high. But just as with Depakote, if you do see a child on lithium, they have to get their labs. That's so important so they can watch the levels to make sure it's therapeutic, but that it hasn't gotten to the toxic level, which can be deadly with any of these medications if they take too much of these medications. But sometimes you'll see lithium used when none of the other mood stabilizers have been effective. Because in the adult world, it is still one of the gold standard medications for the treatment of bipolar disorder. The medication prescribers I work with have just been more reluctant in young children because of the risk of damage to kidneys if the levels get too high. And children aren't always so able to tell you if they're feeling like they're dehydrated or thirsty, and it can become problematic. Lamictal is another mood stabilizer you'll see used, as is Trileptal and Tegretol. These medications can also be used for seizures. So if a child's on Depakote, Lamictal, Trileptal, or Tegretol, I would want to make sure I knew the purpose of the medication. so that if it's for seizures, you know there is a history of seizure disorder. If it's for mood stabilization, that you know it's for that. Most common side effects for this classification of meds is going to be sedation. They're going to be sleepy, especially shortly after starting it. Weight gain, as I mentioned, is more common, and then stomach upset. Again, I always recommend taking these medications with food just to sort of cushion the landing in the stomach. Are there questions about the mood stabilizers and the anticonvulsants that we're talking about here today?
We have not had any come in, and so unless someone just sends one really quickly, we will go ahead and answer the rest of the questions at the end if someone thinks of one.
Okay. I do want to let folks know that the issue of bipolar disorder in very young children is something currently being reviewed in the DSM-5, and we may have a different classification for these very young children who are having great difficulty regulating their emotions. Right now, those kids often get lumped under the bipolar disorder of some type, maybe bipolar NOS, bipolar 1, bipolar 2. They kind of get categorized there. But they're really thinking, based on some longitudinal studies now, that show most of those kids don't end up with an adult bipolar disorder. They often end up with a different diagnosis as adults, that probably this is a different issue going on with these young children. Even though the medications can be very helpful, same medications, they're looking at some sort of a diagnostic grouping around emotional dysregulation. When we see these children in our preschool program, often they're children who've had a number of disruptions in their early life, maybe disruptions in caregivers, disruptions in the family structure, maybe trauma, maybe abuse, and there's probably some other things going on with those children than the classic bipolar disorder in adults. So just want to kind of let people know about that, and hopefully in the next year or so the new DSM is out, and there will undoubtedly be trainings out there on this issue for folks. So I'm going to move on to yes, go ahead.
Sorry to interrupt. We did have one question come in about mood stabilizers. If you'd like to answer it, it is, what is the typical age range for mood stabilizers being prescribed?
Well, I don't know what the statewide practice would be. I probably can only speak to the practice I see where I work at a community mental health center. And we do serve a lot of children. We serve about 1,000 children in Sedgwick County. At the mental health center where I work, I rarely see preschoolers on a mood stabilizer. And it does happen, but it's typically after a number of other medications have been tried and have not worked, that you may see somebody try, at least at my place, one of the mood stabilizers. You would see it in a very young child who has a history of seizure disorders. You may see one of those medications being used, but it would be, at least where I'm at, an unusual situation, and it would be because there are very serious concerns about the child's safety to themselves or others that has not been resolved with other medications.
Okay, great. Thank you.
Sure. Lastly, I'm going to talk a little bit today about antipsychotics. And antipsychotics really have been broadened to treat a number of other disorders besides just schizophrenia. Most of the medications we'll talk about today got their start in the treatment of schizophrenia, but it's been discovered that they can help with other disorders as well. Many of the medications we'll talk about have now obtained FDA approval for the treatment of bipolar disorder, and in some cases, such as Abilify, for the treatment of treatment-resistant depression that has not been, the depressive symptoms have not been resolved with a typical antidepressant, and they may add Abilify on top of an antidepressant to help in resolving those remaining symptoms. So just because these are antipsychotics, it does not necessarily mean it's being used to treat psychosis. Many of these have been broadened beyond that. They are often used to treat excessive and extreme aggression. Some of these have received FDA approval for the treatment of aggression and self-harming behavior in children who have an autism spectrum disorder. I believe Risperdal is one of those medications. So let's talk a little bit about the meds. Risperdal has been out now for quite a while. I do see it being used in very small doses. It can be dosed down to, I believe, as little as 0.5 milligram, a very, very small dose. I've seen that one used in younger children where there is extreme aggression, harming of self and others that has not been resolved in maybe other therapeutic ways, like through treatment. You may see Risperdal used. Invega is a form of Risperdal that's longer acting. Typically, Risperdal you're going to see dosed twice a day, sometimes just once a day, but most of the time it's going to be twice a day dosing. Invega is more often just a once a day dosing, but the medication compound is really about the same. You may also have started hearing about a Consta and a Sustaina shot. I rarely, if ever, see these used in young children, but I have seen them used in adolescents where there are concerns about medication compliance, that they're not taking their meds. More often for individuals who have schizophrenia or a more typical bipolar presentation. The Consta shot appears to last about 2 weeks, so you have to get it every 2 weeks. The Sustaina shot is a once-a-month dosing, once-a-month shot. So you don't have to take the daily pill. It does last longer. I have not seen folks using those in young children yet, and I don't know if we will, but you may hear about them, and they are injectables. They are a form of Risperdal out there. Seroquel is another medication I see used in young children for the same reasons as Risperdal. More often it's because of emotional dysregulation, aggression, excessive temper outbursts, temper tantrums that are lasting hours, and we're not able to get them under control and resolved through behavioral management type techniques or parenting strategies, and then we try a medication. Seroquel of these medications is one that is sedating. Often the first 2 weeks they start the medication, they're going to be sleepy and they will need more sleep at night, and we need to make sure they have that time to get that sleep. Then typically that'll pass, but if the dose is raised, you may go through another couple weeks of sedation until they get used to the med, it kind of gets on board, and that typically passes. We talked a little bit about Abilify, it being used for both psychosis, but as well as for mood disorders as an adjunct to an antidepressant, and I do see it used for children who have aggression, extreme aggression. I don't see Zyprexa used much anymore, but it is out there, and you may come across the child on it. The reason I haven't seen Zyprexa used much since we have newer medications is because of the weight gain. This is another medication that is notorious for causing significant weight gains, 20, 30 pounds. And for some adults who were on this medication and adolescents with the weight gain, they also started seeing some increase in type 2 diabetes, probably because of the weight gain, probably not so much about the medication itself, but whenever you gain a significant amount of weight, your risk of type 2 diabetes goes up. So it's out there, you may see it, but we don't see it a lot. It's also very sedating for folks. And so anyway, Geodon is another medication you'll see. I've seen it used in preschoolers for the same reasons as Risperdal, Seroquel, and Abilify. Clozaril I have not seen used in very young children. I have seen it used in a little bit older children when they have tried all the other antipsychotics without success. Clozaril I started seeing used in the early 90s with adults who were being deinstitutionalized, and it can be an extremely effective medication. It has a very serious potential side effect, which is it causes the individual to quit producing white blood cells, so they can't fight off infection, and they can die from it. It's potentially lethal. Very, very rare. Out of all the people I've ever seen on Clozaril since '92, I'm only aware of 2 cases where their white, and it was adults, where their white blood cell count became too low and they had to stop the medication. Typically happens shortly after starting it, but they also have to get blood levels done to check their white blood cell counts, which is why you're not really probably going to see it in very young children out there. There's a new medication out called Safras, and the reason I left Clozaril in here is Safras chemically is closest to Clozaril, but there's no risk of the white blood cell count issue. They don't need labs for it, and it's a sublingual, which means it dissolves under the tongue. They're little strips. They are now flavored like cherry, I think, flavored, black cherry flavored, where if you can get the strip in the child's mouth, it'll dissolve, and it's effective very quickly. So again, for a child maybe who doesn't like taking pills, this might be a medication to talk to a prescriber about. But it's very new. We are just starting to see children on this medication. The most common side effect of any of this class of medication is going to be weight gain and sedation, that they're sleepy. We really work with families to make sure kids with these medications get enough sleep, or you may see them sleepy at the afternoon at school because they do need more sleep. There's some less common side effects, which I'm only going to briefly talk about, and I really stress to people, don't try to remember the names, just remember the symptoms, and that, you know, if you see these things, we really need to get them to the attention of a medical provider quickly, because these are very, very serious potential side effects, and neuroleptic malignant syndrome can be fatal. So rare, these are exceedingly rare, but there's a risk with any antipsychotics that these can happen. So with akathisia, what I really tell people is it's an intense, restless feeling inside, like they can't stop moving. They may walk around the room, they may be rocking, they may be pacing, they may be moving their toes inside their shoes, they just can't sit still. And this isn't like hyperactivity. This starts after they start taking one of these medications. It's a change from the child's baseline, and they may become irritable because of this kind of restless feeling that they can't stop. And it's important to talk to the prescribing physician because there are some medicines that they can give them that'll counteract this side effect. I saw in some adults, not so much in young children, but in some adults, that this became so unpleasant for them that they began to think about suicide. And there is treatment for this side effect. It can be resolved. We just need to be mindful of it and let a prescriber know if we see it. Tardive dyskinesia is a little more serious. It's involuntary movements, almost kind of Parkinson's type movements that you may see in the limbs, in the jaw, in the mouth, or the tongue. I've seen individuals who do tongue rolling when this has happened to them. It's more common when somebody's been on an antipsychotic for a very, very long time. And it's also more common in older persons than in the young. It's critical that you notify a prescriber as soon as possible if you see this, because if it's left untreated, these can become permanent. And I did work with some adults in my career who were on some old antipsychotics like Thorazine, developed tardive dyskinesia. It was not addressed in time, and it became a permanent involuntary movement for them, which was really distressful. For them to have that, and there was really little that could be done for that. So if you see some sort of Parkinson's type involuntary movements happening. I've seen kids handshake. I saw a young child's handshaking one time because of Risperdal, and we needed to get them to a physician and get that taken care of, and it was resolved successfully. The last one I'm going to talk a bit about is neuroleptic malignant syndrome. This is potentially life-threatening. It is probably best described as looking like a severe case of the flu. They can spike a high fever, they can become hypertensive, high blood pressure, tremors, incontinent for a child who has not had problems with wetting themselves. If they're running this high fever, they're stiff, they're losing control of their bladder, I would definitely get them seen by a physician immediately, as in an emergency room. I have only seen this happen once in my career, but it did happen with a child on one of the newer antipsychotics, and it was fortunate that we knew, the providers who were seeing the child on a regular basis knew, and were able to recognize this probably wasn't the flu, and we got that child to an emergency room and got this taken care of very quickly. So again, these last three, they're very serious. I try to educate people about them. Don't focus on remembering the names, but just kind of the sense of restlessness, can't stop moving. For the first one, the middle one's more involuntary rhythmic movements, kind of Parkinson's type movements, and then this last one is more like a severe case of the flu, getting that checked out with a physician to make sure it really is the flu. So we're about out of time. I do want to take any questions we might have remaining.
We did have one question come in, Jody. It's how long does it take to reach a therapeutic dose? And I believe the question was in reference to Seroquel.
Sure. It depends on the prescriber and how quickly they titrate up. If it's done in an outpatient setting, it could be several weeks to a month or more before the prescriber feels like they've had time to raise the dose. They may take it very slowly. If these medications are started in an inpatient setting, often they feel more comfortable increasing the dose more quickly to get to that therapeutic level. So it's really, you're going to have to play it by ear with the prescriber, but it could take quite a while.
Okay, great. Thank you. Well, would it be all right if we provide your email address on your handout that we post on the keccs.org website in case people have further questions?
Absolutely.
Okay.
There is a one-page handout, which I kind of call a cheat sheet, and I made it one page so that it's easy to keep a hold of and carry around with you if you need it, that kind of summarizes much of what we talked about today.
Great. Okay. Well, that will be on the keccs.org website, and we will make sure that Jody's email address is on there. So if you have any further questions, you can email her. But thank you so much, Jody, for the great information. We really enjoyed the webinar. Just a couple of closing announcements. If you've been on a webinar earlier this week, you know that we're having a weekly series, and so tomorrow is the last webinar, and it is on compassion, fatigue, and self-care for emotionally demanding occupations, and that is with Diane Barker-Harold. She's a great presenter, so I would encourage you to attend that webinar. You can register on the keccs.org website. And let's see. You will receive a survey, so if you could complete that, we would really appreciate the feedback. And if you would like a certificate for attending today's session, please send me an email, and we will make sure that you get a certificate if you need it for continuing education. Or if you have any other questions, please send me an email. But we greatly appreciate you attending today. Thanks again, Jody, for a wonderful presentation. It's great information that is very valuable to those of us working in early childhood. So we appreciate your time, and thank you all for attending the webinar, and we will hopefully see you tomorrow on tomorrow's webinar.
Thank you.